Hello, everyone.
Hi, Mitchell.
And hello there. And let me check first, Levi, is everyone hearing me or just the panelists?
Everybody should be able to hear you.
Fantastic. Oh, thank you, Julie, who said, I won't say anything too confidential, but we're delighted to welcome everybody, the panelists who you'll hear from very shortly, as well as all of you attending to this incredibly exciting and important webinar about the Dapivirine vaginal ring. We're going to get started in just a couple of minutes as people join. Want to make sure I see Zita, Cleo, Rachel, and Ruth, and Manju, you're all on. And maybe just do a quick sound check, if we can hear all of you.
Hi, Mitchell. This is Rachel.
Welcome.
Welcome. It's Manju. Hi, Rachel.
Yeah, and this is Ruth on. Hello,
Fabulous.
how are you?
Welcome, Ruth.
Yeah.
Hey,
thanks.
Michelle. This is Cleopatra.
Cleopatra, delighted to have you. And Zita, you're there, I know.
Yes.
Fantastic. We are going to get started in just a minute. And Levi, you have the slides, correct, that you're going to post up?
I do, yes.
Fantastic. We will start in just a minute. Again, if you're dialing in, welcome to this webinar about the Dapivirine vaginal ring. We are going to start momentarily. I'm just waiting for some additional people are dialing in. But we do have a lot to get through, so I think perhaps we will get started. We clearly have critical mass, and I am delighted about that, and all of us at AVAC are delighted about it. Because in the midst of what is clearly unprecedented times, incredibly challenging times, frankly, I think for many of us all over the world, very depressing times, good news is especially welcome. And in the HIV response, any time is an important and good time for good, important, impactful news in the AIDS response. And so this webinar is one that is many years in the making, and one that we are all at AVAC delighted, and our partners delighted to welcome everyone to. There's probably not much need for a spoiler alert. We're here to really get an update on the newest prevention option to enter into the reality of public health beyond the research phase. And many people on the line are part of this story. And I just have to say, I just saw a quick note from probably the godmother of all of this, and that's Zena Stain. I'm so glad, Zena, you are on. I can remember back to the days of an AIDS conference in Yokohama many, many years ago, when the idea of a female-initiated method was first proposed by you. As a dream, as an idea, as an essential need in the AIDS response. And it has taken too long to get us to today, but we are here, and we are delighted to welcome all of you, advocates, policymakers, funders, researchers, women's health activists, all, and really just want to welcome everyone to the call. Let me do a quick logistics run of show. I'm going to, in just a minute, welcome Zita Rosenberg from IPM, Rachel Bagley from WHO to provide initial inputs and updates. I'm then going to turn it over to my dear friend and colleague Manju Chachani Gada from AVAC, who's going to take on introducing and welcoming Ruth Naharira and Cleopatra Makura to engage them in an initial conversation, and then we want to engage all of you. I will encourage you to feel free to post Q&A as we go and chat. Manju and I will do our utmost to bring all of those questions to bear in the conversation that will unfold. We undoubtedly won't get to it all, and you can rest assured that we will work with IPM and advocates in WHO to keep the conversation and the questions coming. So do please put your Q&A and comments in, and we'll get to what we can. We'll also look for hands later in the call. But again, when I think back on the history, beginning with Zina many years ago, and then over the last 20 years from Zina to Zita, and Zita Rosenberg, as all of you know, is the founder and Chief Executive Officer of the International Partnership for Microbicides. I will say Zita has been an amazing mentor and colleague and friend over many years in this work. And I can remember when IPM started with a big idea as one of many product development partnerships that have been started over the last 2 decades, with big ideas to develop products, to take them through product development, to get them approved, and to make them accessible to the people who need them in HIV and TB and malaria, in neglected tropical diseases. It's a big idea, these product development partnerships. And the reality is very few have actually gone from the initial idea of a product to negotiating with companies, to creating a pipeline of ideas, to making scientifically difficult decisions about products that won't keep going and don't warrant continued development, to prioritize products that do, to navigate funders and politics and personalities, to navigate advocates sometimes. And Zita has done that with absolute grace and skill. And so this call is both an update, but also I do want to make sure we take a moment to celebrate not just IPM and the thousands of women who participated in clinical trials and all the funders and supporters of that effort, but it does take leadership, and Zita, you have provided that. So before we get too much into the details of the excitement and what comes next in this work, I do want to just take a moment to thank you and to congratulate you for what you have done with all of your colleagues at IPM and with all of the partners that you work with to bring us to this place to have a webinar about next steps for the first female-initiated product since 1993, a long time in coming. So with that, I'm delighted to welcome you and to turn it over to you to give us an update on the EMA opinion and what's going to keep you up at night now, differently than what's kept you up at night for the last 20 years.
Thank you, Mitchell, so much. I think the most common word that has been used to describe me in both recently and in the past is stubborn. So yeah, stubbornness helps, I guess. But thank you all. And this really has been a culmination, a collective effort of so many people, institutions, partners, the women participating in the trials, all of our advocate colleagues and friends. And I must say, we've never had run-ins with activists. They've been wonderful supporters and advocates for us. I can't say the same for other donors in other groups, but you know, it's the life of the ring. It's the life of a nonprofit. But Zina, I am so happy you're on because you started it all. And I know Chris Elias and Lori and Polly, and I've heard from everybody, and Alan Stone, and it's really wonderful to know the shoulders that we have all been standing on to get to where we are. So thank you, everybody, for helping us get to this point. So next slide, please. Okay, so oftentimes, and especially recently, people saying, why did IPM develop the ring? And you know, a vaginal ring for contraception was certainly not a novel idea. And it's something that many of the microbicide supporters in the past had mentioned as a possibility. WHO had looked at it for contraception. Conrad, a lot of folks had thought about a ring for a microbicide, and we were just fortunate enough to be able to work initially with the POP Council, and then with other groups, and then finally kind of solo on the ring. And we were lucky enough that Dapivirine was a great drug that got into a ring, and amazingly to us got out of a ring. And it all just kind of fell into place with many stumbles along the way. But we initially developed the ring, and the entire microbicide field arose because available methods were not doing enough to slow the epidemic among women. We all know that. We also knew that women needed products that they could use on their own terms, discrete products. We also knew that no one product or category of products was going to solve the HIV epidemic. And because of all of the work that had gone into the contraceptive field over many, many decades, we knew that women needed many options that make sense for their lives that could be used either on demand or every day or monthly or longer. And we also knew that women want a choice of either systemic or non-systemic products. So that's why we developed the ring, because we thought it would offer women choice. Next slide, please.
Hello.
Oh, okay. So you all probably know this as well as I do. The ring is a flexible silicone ring. Women can put it in themselves. They take it out. They replace it every month. It can be used with or without partner knowledge. Most men didn't know that the ring was there unless they were told. It does not interfere with sex. It slowly releases the antiretroviral drug Dapivirine, which Janssen Sciences Ireland graciously gave us exclusive worldwide rights to. We were able to show with our important partner, the MTN, that the ring reduced the risk of HIV infection by 35% in the ring study and 27% in Aspire, both of those phase 3 trials. And then there were 2 open label extension studies that were conducted by MTN and by IPM. We saw increased adherence, and which suggested greater risk reduction. When we looked at comparing to modeled placebo incidence rates, it equaled between the 2 of them about 50% reduction. Again, the only numbers that can really be used are the ring study, 35%, and Aspire, 27%. And of course, it is now the first long-acting HIV prevention product that has received a positive opinion. Next slide, please. And next slide, because I know you all want to know what the next steps are. And that is indeed what keeps all of us at IPM up at night, making sure that the ring is accessible to women in the highest risk settings in Africa. And in order to do that, we need African regulatory approvals. Every country in Africa makes the decision, as is their right, as to whether the Dapivirine ring should be used by women in their country. So the reason we went to the EMA is because they have a process, which is called Article 58, that allows for review of products that are intended for use in developing countries, to have them reviewed under the same rigorous standards as for products intended for use in the European Union. But what happens under Article 58 is that the WHO is involved, and many African regulators are invited as observers. And we thought that that would all help set the stage for what has to happen next in Africa. The positive opinion of the EMA is recognized by many national regulators in Africa. It helps with an abbreviated WHO pre-qualification. It helps with guidelines, and all of that I know Rachel will be talking about, so I won't talk very much about it. But clearly, this opinion is a key step on the path to making the ring available where it's most urgently needed. But it doesn't get us all the way there. So what are the other steps that we need? Next slide, please. Lots of different steps. We are right now with the green box, which is the WHO. We are there, and Rachel will talk all about that with guidelines and expression of interest, et cetera, and PQ. In parallel, in that oval circle, IPM requests to WHO and the African National Medicines Research Agencies for a collaborative review procedure. And that will hopefully facilitate and abbreviate some of the time that would be necessary to get approvals in Africa. We will see. But we have to submit the Dapivirine ring dossier, all the information that was submitted to the EMA, and perhaps even additional information that was generated since then. We submit that to the African regulatory agencies via this collaborative review procedure. We anticipate submitting these by the end of this year, many of them, and then we will await the approvals. And this includes South Africa, as well as all of the other sub-Saharan African countries that abide by this collaborative review procedure. And if they don't, then we will look at directly interacting with these countries. We are also going to be submitting to the US FDA, and that planned submission is also by the end of this year. So a lot of work has to happen between now and the end of the year, but it's critical work on the path to making the ring available to women. Next slide, please. And hopefully, next slide, once we do have national regulatory approvals, we can begin rollout. But that isn't a simple effort. There is a lot of work that goes into planning for rollout, and even once rollout initiates. And the many categories, of course, include government and donor support. This all will take a lot of money. It equally includes the end user access. How do we tell women and encourage women about this product to drive women's awareness and education and use of the ring? And then it involves the clinic and public hospital access. How do we work with providers so that they know the messages that women need to hear? The operations and logistics, how we get the ring to the clinics and hospitals. All of this takes a huge partnership, and it could be a different partnership at every country, depending on who has the most experience and success in rolling out products in each country. And clearly IPM is but a small player in all of this. But we will be working with many, many others to form these partnerships, and hopefully there will be independent organizations to lead these partnerships to get the ring to where it goes. But we have committed to all of our donors that we will be involved and ensure that the ring gets to where it has to go. So that is our commitment to all of our donors. Next slide, please. And there's a lot of work that is still going on. We will be working as a result of the EMA opinion on what's called a phase 4 post-authorization study among young women, 18 to 25, to better understand the ring's efficacy. And that is really critical for the 18 to 21-year-olds to see how we can inform adherence support strategies and just to better understand the ring's efficacy in general and to confirm the ring's efficacy in this area. We will also be collecting data on ARV resistance, as everyone knows is important for ARV-based microbicides. And there is a lot of work that is going on with the Microbicide Trials Network in partnership with IPM. The REACH study is ongoing, again, looking at adolescent girls and young women, comparing Dapivirine ring to oral PrEP in terms of safety and adherence, switching it, and then allowing the women to choose. So we can get a sense from young women of what their challenges and preferences are. MTN is also working on 2 really important populations in order to potentially expand the label down the road for pregnant women and for breastfeeding women. And these are really critical studies. so that a woman at any stage of her life may be able to access Dapivirine ring if that is what she chooses. Next slide, please. And there's lots more work that is going on. Again, led by the Microbicide Trials Network, MTN, in partnership with us, looking at longer, long-acting rings. The monthly ring is great. Wouldn't it be nice if there could be increased convenience for women who choose to leave a product in for more than a month, say 3 months? It certainly would lower annual costs of having 4 rings a year rather than 12, which is going to be really an important consideration for ministries of finance, as well as for procurers such as PEPFAR and the Global Fund. This 3-month Dapivirine ring has already been tested in phase 1. We will have the results soon. And there is also a Dapivirine levonorgestrel ring, again, lasting for 3 months for HIV prevention and contraception. The second phase 1 trial, results are expected soon. But in the first phase 1, it was well tolerated with encouraging drug levels in blood and vaginal fluid. So lots of things happening next, but all of these were predicated on the ability to get Dapivirine ring approved in African countries. So that pathway is still our #1 priority. Next slide, please. This may be, yeah, here we go. It's coming slowly. You want to hit the next button? And the next. Here we go. Whoop, there. So we are just so excited when we were kind of hearing back and forth from EMA and wondering what was going on, and we were getting encouraging news. And Patricia Meyer-Brennan, who heads IPM's regulatory department, who you could imagine has been incredibly busy with all of this, was saying that she felt like, we were like landing on the moon. It was like that exciting and that tense. One first step for women, one great giant step for womankind. So it was just all really very exciting, but it is about the women, right? That's why we did this. That's what we have to keep our eye on, the ball, which is making this ring accessible to women. And so, that is just so important to us. And we will not rest nor sleep until that happens. Next slide. And these are our donors. There are many, many donors over the last, 15 years. These are our current donors, but we thank them all because there is no way we would have been able to get to this point without everyone. And next slide. And on my last slide, we need to thank you and all of you, and especially all of the women who participated in all of the trials, because without them, we wouldn't have learned that the Dapivirine ring works. We wouldn't have learned why it doesn't work for some people. And these are all critical pieces of information to ensure future success of the ring. So thank you all.
Great. Thank you so much, Zita. I'm tempted to ask everybody to go off mute and just maybe give a round of applause, as one would expect in a conference setting or any other public meeting when we might gather together. It is very hard virtually without claps or hugs, but to express everyone's great enthusiasm and admiration and support for all the work you just presented. A lot of great questions have come in, and we're going to get to those as quickly as we can. But as Zita described on that great slide, looking at what comes next, a key partner in this entire process, and particularly in the Article 58 review of the EMA, was the World Health Organization. And their role is always critically important in moving products to access. And the good news is in HIV prevention, we have a remarkable ally and leader in that space at WHO, and Rachel Bagley, without whom voluntary medical male circumcision and oral PrEP would not have gotten as far as they have over the last 13 years, and her leadership there has really been remarkable. We've all learned a lot together, and I know Rachel is keen that we all do better and faster with the Dapivirine vaginal ring than we've done with circumcision or with oral prep. So I'm going to turn it over to you, Rachel, to give us a sense of WHO's perspective and what comes next in this process.
Thank you, Mitchell, and thank you, Zita. I wouldn't say, Zita, that you're stubborn. I think you're dedicated, tenacious, and patient, because, wow, you have come a long way over a long time. And also, of course, a huge shout out to the researchers, to the donors, to the women in the trials, and also a massive contribution to this work has been the advocates and the women and the women's groups who have really been there supporting this and advocating for this. And I think many of you are on the call, and this certainly would not have happened without you. It has been a long time coming, and this process with the European medical agencies has been difficult, because it's a difficult thing to assess. A product that is being evaluated on an intention to treat basis is very, very complicated. And so we've always been looking at data which doesn't necessarily show, in inverted commas, a true efficacy. It shows an efficacy for those overall, for those who take it and for those who don't. And it's difficult, therefore, always to consider out an opinion. And that has been one of the problems. However, we've got there. We have a positive opinion. And WHO hasn't been sitting, waiting for this to happen. We've been following this and working with the EMA and working behind the scenes while EMA has been looking at all the data. And we have already, done our own systematic review, which we will do a further update. We've worked with others on values and preferences. There is a lot of information and published data on values and preferences for prevention choices. We've also looking at costs and feasibility, and we have a time slot where we will look at this as part of the update of our consolidated antiretroviral guidelines. And that will happen in September. And this is the usual process that WHO has to look at all new recommendations. So I can't tell you what we will say. It will be up to our guideline group, but we will prepare the ground so that they have all the evidence to support them making a decision. And Michelle Rudolph, my colleague at WHO, will be leading this. Again, as to echo Zita, to have an additional choice for women where, so often we haven't got many choices for women, will be an important part of discussing that. And I think, we are also very keen to see, and it's fantastic that IPM and others are really thinking about the future, because it doesn't stop there. And I think to have a combination ring for contraception and HIV prevention, a longer life of the product will have huge benefits. And on the regulatory process as well, we haven't just been waiting for EMA. We've already had one small meeting with African regulators to tell them that this is coming on board, and so that they're aware of the product. And again, we're aware that EMA will be making a decision. And we will work very closely with our colleagues in pre-qualification to make sure that things can go as smoothly as possible. We are waiting some further data, of course, as Zita says, looking at some of the safety issues for younger women in pregnancy and for drug resistance. But I think, we're very hopeful that this will be relatively straightforward, as one of the major advantages of the Dapivirine ring is that it acts locally, and so adverse events, which one can potentially see with more systemic products, are unlikely to be a problem. I think, as with all prevention for women, we will have to be very careful about making sure that services that would offer this product are done in a comprehensive way. We know that STIs continue to be a significant problem, often asymptomatic. We need to take this seriously with better diagnostics and better treatment for women, alongside offering a range of contraceptive choices, and addressing always intimate partner violence as part of HIV prevention services. And I think what we need to do to prepare is to continue this engagement with communities. We know that both, as Mitchell says, with medical male circumcision and with PrEP, part of the slowness in getting uptake has been getting communities to be fully aware, giving them the opportunity to ask questions and discuss how they would like a product to be delivered. And this is a new product. It's a new way of offering prevention. And a lot of the success will be on communities really understanding that. And that's why it's so fantastic to have such strong African women advocates, because it's going to be you, many of you on the call, who are going to be doing this work. So I will stop there, and we have exciting times and a lot of work to do over the next few months. Thank you.
Great. Rachel, thank you so very much. That was terrific and really helped frame a lot of what comes next. And your final comments are the perfect segue for me to hand this over to my colleague, Manju Chaitani, who all of you know on the line, who leads a number of initiatives at AVAC, including our Advocacy Fellows program that really has, for now over a decade, really led a lot of the ring advocacy, and thanks to Manju's great leadership and mentorship in that work. I'm glad to turn over to Manju to welcome two additional panelists, African women leaders, to join Rachel and Zita to talk about the way forward. So Manju, over to you.
Thanks so much, Mitchell. And hi, everyone. Again, it is so exciting to be having this call to discuss this really exciting news for HIV prevention, and especially for women. Please let me congratulate Zita and IPM again on this news, as well as the thousands and thousands of trial participants and policymakers, researchers, funders, and advocates who made this happen. And it's really lovely to see so many names in the participant list today of people who've been involved in this work for decades now. The future of this product will also require the community, this village who brought it here, to all be involved. And so thank you to WHO. With Rachel and Michelle's leadership, we really look to you to move this forward as speedily as is possible. But this wouldn't have happened without the trial participants and, like Zita said, the advocates who've really been engaged in this process. And so we see there are tons and tons of questions that have come in, and we will get to as many as we can. But first, we wanted to hear from them. So first, it is my true pleasure to introduce Ruth Nahurira. Ruth is a former trial participant in one of the phase 3 clinical trials of the ring, the ASPIRE study, and the open label extension that followed. She's a longtime community leader. She's part of the Community Advisory Board for the Infectious Diseases Institute in Uganda. She has been an advocate for women's health for a long time, and currently she's working on her MBA. So Ruth, thank you. Thank you for joining us, but also thank you for being part of one of the trials. We'd love to hear your thoughts about this opinion from the EMA and what you would like to see happen next. Ruth?
Thank you, Manju. I'm very glad today. I really thank you for the invite. I thank you all for let me start with my expression of joy. I'm very happy. I cannot express how happy I am to hear about the good news of this ring and where it has come from and where it is today. I'm very glad to hear that it has passed this test, and I'm very hopeful to see it here in Uganda, in Africa. I really thank all the stakeholders that have taken part in bringing it to this level. I want to thank everyone for all your efforts. I want to thank the donors. I want to thank the participants. I want to thank the doctors, everyone in their category. I'm very happy. I'm filled with joy. You cannot, I cannot underestimate what I feel for the ring, because I'm this person who has been with this ring from the Aspire study out to the open label study, and now I've been waiting for beautiful results that like these that have started to come out. So I'm very, very glad that I am part of the team, and I'm very happy that women are going to get the first long-acting HIV prevention method, and I'm very happy that other women in the world are going to share what I tested, because this was something that gave me a great experience in HIV prevention. I'll give you a brief on my experience on the usage. It was on my own terms, like I would use it and no one would even know that I have it. Even my partner didn't feel it for all those years. I used it for nearly 5 years, that is in the Aspire and here in the open label, 4+ years. So I'm very happy about the progress that it has made. To my questions on the expectations of the product, many have been answered in the presentation that we have had, because really I wanted to see what happens next. So I really enjoyed the slide of what happens next, because I can't wait to see it here in Africa. Yeah, and then about my expectations of the product is I've always gotten worried of maybe the pricing and the affordability. It's glad to hear that you are talking about focusing on Africa and making this option reach out to the women in Africa. But the economic status here is not as good as we see in developed countries, because this is another country that is low developed and still developing, and the levels of income are low. So if you could please see if there is a way how affordability could be, it could be like how the prices could be tailored, so that even if it continues to come here to the ground and people get to pick interest in it, which I'm sure that will happen. I'm sure that women will use it. We'll also look at that affordability bit of the product. Yes, then I'm very glad that I also saw a slide on distribution, on how they're going to involve the health centers, and I think all my concerns were really answered. I thank you, Zida, for the good presentation that I've had. So mostly I really, apart from the affordability and the distribution which is being worked on, I really think that I'm only swimming in my joy here and my happiness for this milestone reached. And I can't thank everyone enough, all the stakeholders in their capacity, for help us with our ring to come this far. Thank you very much. Back to Manju.
Thank you so much, Ruth, and thank you so much for joining us today. I know that if you're looking at the comments, there are a lot of people that are very excited that you are here with us today. So please stay on in case people won't have any questions for you. And next, I am delighted to introduce you to Cleopatra Makura from Zimbabwe. Cleo is a youth prevention advocate from Zimbabwe. As a 29 AVAC fellow, she catalyzed PrEP access in some tertiary institutions there. And among the many platforms for advocacy, she also provided testimony to the EMA when they were making their final decision and voting on whether to give a positive opinion on the ring. So we are very grateful also to Cleo for whatever she said to convince people. Cleo, we'd love to hear your thoughts about the opinion from the EMA and how you and other young women have been talking about wanting to be involved in the future of this product. Cleo?
Thank you so much, Manju. I am also very excited, like Ruth has said, and I'm sure Ruth has thanked almost everyone. And I would also like to thank everyone who has been involved and who also keep on being involved in the advocacy of the ring. So I'm excited with the positive opinion by the EMA and the fact that it's an option that empowers us to be able to decide on our own health. So most of the prevention options we had did not give us the power over our health. Young women need now to be educated and be given appropriate information about the ring, because the ring has not been approved in country, and there's a lot of advocacy that still needs to be done to ensure that our ministries and country medicines authorities also adopt and approve the ring. But before it is introduced, we need to continue educating the women about the efficacy of the ring, and we need to learn from the VMMC, where some men thought that it's a green light to have unprotected sex. So we still need to engage young women so that they are empowered to use the ring correctly, as the ring is just an addition to the already existing HIV prevention methods when it becomes available. So just like Ruth has also highlighted, price will be very important to make sure that women and young women can easily access the ring. So I'm just thinking, what is the price, and what's like the price we're envisioning for that, and what are we also planning to do that we support access? Because availability is one thing, but also access is another thing. Back to you, Manju.
Thanks so much, Cleo. So thanks for also your questions to Zita and to Rachel. So before we go to the many questions that have come in, first I just want to thank both of you for all that you've done and for your energy to continue this work. But we want to open it up for questions now. There are tons of comments also that have come into the chat. Many of these are lovely comments and our suggestions, but there are also many questions. Some that came in before and some that are there now, as well as some hands up. So we'll try to get as many as we can. But first, both Ruth and Cleo asked about affordability of the ring and what will be done to ensure access to women who participated in the trial, especially, but to really enhance access. And I wanted to give Zita a chance to respond to some of them before we opened it up for more questions.
Sure, thank you, Manju. We are prioritizing the countries for regulatory approval that participated in the clinical studies. So our goal really is hopefully to be able to give the women who participated in the studies access to the ring as soon as the countries grant regulatory approval. And so that is clearly top on our list. We have designed and developed the ring to be as inexpensive as possible. And currently, the price of the ring at very low volumes with the approved manufacturing process from the EMA is $8 a ring. With higher volumes and some relatively minor tweaks to manufacturing, that number will come down. We are working with procurers and are trying our best to have the ring, once it receives approval in African countries and once the countries request the ring, that it be approvable under PEPFAR, Global Fund. So all of the ways that the ring might be available to women at low or no cost.
Thanks, Zita. That's useful to hear. There is a couple of questions that have been coming in about access or accelerated access for past trial participants. I wonder if you want to take that on as well.
I'm sorry, could you repeat that?
Sure. About access or accelerated access for past trial participants.
We certainly can look into those mechanisms for sure, because rings will be available. And so that certainly will be looked at. I think that's an excellent idea.
Excellent. So before we go to some people who have raised their hand, let me also just ask this question to Rachel. While WHO was part of the Article 58 review and decision process, why should it take another X months or years before a pre-qualification signal?
So, hopefully it won't take years. What we always try to do is be in sync with the stringent regulatory authorities. So we really had to wait until we had a positive decision from the EMA to now start the process. But as Zita has said, having had a positive opinion from the EMA, we can now go ahead and work through our systems. And as I say, I hope it will not be too lengthy, and it certainly shouldn't be a stumbling block. And in the meantime, we can continue all those discussions with the Pan-Africa regulators and the in-country regulators to make them aware of this and to push this forward. And my team, my colleagues, we aren't directly responsible for the pre-qualification process. We're responsible for the recommendations on products, and those, of course, again have to go hand in hand. We couldn't have we couldn't have had a recommendation without a product. So again, we've committed to be as quick as we possibly can through our guidelines process, which is why we have done a lot of preparatory work, and we'll have that decision in September. So we will do everything to hold things up, but we really hope that a lot of the things that I mentioned will be happening in the meantime to get communities prepared, to get the systems in place, the ways that services can be delivered that are maximally acceptable for women, and all the information that communities need. I did notice in the chat box, somebody said, and I think this is a really important point, once people know something works and are familiar with it, it's quite likely that adherence will be higher and efficacy will therefore be higher. And we've certainly seen that, you know, from the early trials of oral PrEP. You know, some of the first trials of oral PrEP didn't show any impact in women, and it's really because women didn't know that they were taking a product that was going to be beneficial. It was only when we had some of the later trials that we really got a positive result for that. And the same with the trials in PrEP for men who have sex with men. The early trials didn't have this huge impact that we now see with oral PrEP. It's through learning that you've got a product that is effective and you feel motivated and really want to use it, that we're likely to see a better result.
Thanks so much for that, Rachel. The one question I have to ask you before I let you go and ask questions that have come up is from a number of people that said, how can advocates be involved in some of these WHO processes? How can we advocate but also be involved in any of the decision making? Is there a way you can suggest and that we can advocate for advocates to be involved?
When we have already our guidelines review committee, our guidelines review group, which has been established for the whole guidelines review process for our antiretroviral guidelines, and I think this is, you know, this is very good because it will mean that we're very transparent, objective, to help us make a recommendation. In that, once that recommendation has been made, we have a peer review process. So we'd be very happy to receive requests from people who would like to be able to review that section of the guideline. But I think really the critical thing is in country is to really use your voices, to let your ministries of health and implementers know that this is something that you would like them to, and you would like them to start implementing, thinking about while the regulatory processes and the guidelines are being finalized.
Thank you. Another sets of questions that are coming in are, and I'm thinking, Zita, you will be able to help us with this one, is what might be the sources of ongoing financial support from the US government going forward?
Well, I know many of our USAID colleagues are on the phone, likely PEPFAR colleagues as well, and USAID has been instrumental in support for the ring. And my hope and prayers are that they will continue, as well as through, really importantly, if possible, PEPFAR procurement of the ring. So I think that US government support is clearly going to be critical. There still are the continuing studies from the MTN. So I think that again, through NIH is going to be really important, as well as for the 3-month ring and the contraceptive Dapivirine ring. So my hope is that the US government will be supportive for both access and ongoing product development.
Thanks, Zita. So I'm gonna actually head to the phone lines now, and Yvette Raphael, Yvette, I see your hand up. Do you have a brief question? You can unmute.
Unmute. Okay. Hi, can everyone hear me?
Yes, comrade.
Okay. Thank you so much. First of all, I'd like to say congratulations to IPM, to Zita and her team, to all of the trial participants and the advocates. I think my question would go, and I put it in the chat box, but I think I would like to rephrase it and saying to Rachel, with the previous experiences, with the ECHO trial results, and how advocates were involved and participated, what will the process be to getting advocates part of the guideline reviews and recommendation, ensuring that regardless of whether the ring is part of the HIV, ARV therapy group, that advocates, young women, are at the table when the reviews are done, and how can we ensure that that happens with discussion, being in discussion with WHO and the channels thereof from, I want to say today, but let's say from now on. Thank you so much and congratulations. I'm ecstatic about this.
Thank you so much, Yvette. Maybe we'll also take a question. I can see Alan Stone has his hand up. Alan, do you want to ask your question? You can unmute. What? Oh, there he is. Go ahead, Alan. Unfortunately, we cannot hear you, Alan. I wonder if you could type your question in the box, if you don't mind. Thank you. Let me just put one more question then in the line before I ask Zita and Rachel to respond. And this comes from Jim Pickett. And he is talking about the possibility for marketing or authorizing use of the ring in the US. Black women who have high HIV rates in the US want to know if this can be a tool they can use. And as a third question, before we let you answer, I wonder if Sarah Kariuki, who also has her hand up, wants to unmute and ask her question. All right, well, why don't I let Zita and Rachel take these two questions. It seems like coming off mute is a bit of a tech right now. Zita?
Sure. I think the first question was around advocacy and activism with the guidelines process. So I will let Rachel take that. But for Jim's question about the ring distribution and hopeful approval first in the US, IPM's mission is clearly to provide the ring in resource-poor settings, resource-poor countries. Having said that, however, we can certainly and will be planning on sub-licensing the ring to some group, a group that would like to market the ring in the US upon receiving, hopefully, FDA approval. So that will be our plan, that we ourselves will not do it directly, but we would sub-license that effort.
This is Rachel. So Yvette, thank you very much for your question. And I do want to reiterate that it has been the voices of women who have been so critical. And I really want to, again, highlight how Cleopatra and others' participation in the EMA deliberations were really critical. And we will certainly find a way of making sure that women's voices are part of our guidelines meeting, because WHO considers the values and preferences of people who are what we call the end users are as critical as any of the other elements that we look at. And we already have, all the published data and reports on values and preferences of women, which really do really do spell out the need for choice, and particularly choices that women have control over. So these are very, very powerful elements of part of the decision-making group. So Michelle and I will reach out to you, Yvette, and to others to see how you can contribute to this decision-making process for WHO. So thank you very much, and I hope we can rely on you to support us. Thank you.
Many thanks for that. I know that we're almost at time. So for those of you who have to leave, I just want to thank you for joining us, and we'll be sending out links to our page and other FAQs. For those of you who can stay for a few more minutes, I'd love to take on a few more questions. And Zita and Rachel, will you be able to stay with us for just a few more minutes?
Sure.
Excellent. Thank you so much. So those who can stay, fantastic. And those who have to leave, we will also send a recording of the video. So of this webinar, so you won't lose it. I wanted to read out a question that came from Eric Macheka in Malawi. He says, African countries are currently working on PrEP, which is yet to be scaled up in communities that need it most. PrEP is yet to get saturated among our communities to make the difference in HIV epidemic. More work remains to convince policymakers in having PrEP scaled up in countries. Now the ring is good news, but how do we marry the two issues? How do we take the message to policymakers and project the ring as yet another tool in the HIV prevention toolbox without downplaying PrEP? Love for one of you to take that on with your insights on this question.
Rachel, would you like me to start?
Yes, do.
You know, it's a really, really good question. I was reading it when it was up here a few minutes ago, and thought this is a really important question. I'm not sure I have the answer. I certainly don't have the answer. I know that, and we're going to need all of your input at the country level who have been working on oral PrEP, because it is critical from my perspective as a public health person that oral PrEP is scaled up as rapidly and as comprehensively as possible. It has, proven efficacy. We know its efficacy when it's used consistently and correctly. We don't know the upper bound of the efficacy of the ring when used consistently and correctly because of challenges with the half-life of the drug, and being able to detect the drug when the woman is exposed to virus. Its half-life is much shorter. So we have much more information on oral PrEP, and it should be, if I want to use a treatment analogy, it should be first-line prevention. It is critical that if women can use oral PrEP and choose to use oral PrEP, that they have oral PrEP available. So I really wouldn't, I know this is going to sound strange, but I wouldn't want the rollout of the ring in any way to hamper efforts for scale up of oral PrEP. I don't know how we will do that at the country level, but we're going to need all of your help at the country level, all the people who are working with policymakers, to give us suggestions on the best way to encourage the rollout of the ring without harming the scale up of oral PrEP.
Thanks, Zita. There's another question that's come in a couple of times, and the question is about the 35% efficacy level that was in the releases, that this was additional through some additional data collected, that the EMA gave a positive opinion on this 35% efficacy level. Will the WHO Guidelines Review Committee consider this finding and this additional data, or will it need to be peer reviewed and published first? And I'm guessing that question is to Rachel.
Of course, the two trials have been published, so WHO will obviously include both of those, but also include the evidence from the open label extensions, which has estimated a higher efficacy. And as I said before, it is really difficult with these trials where you are not, you're not looking at a product that you can watch and make sure somebody's taking all the time. And also it's not easy to estimate from testing the residual Dapivirine in the ring to say how frequently somebody has used it. So it's in a way, you're getting a kind of worst case scenario from these efficacy studies. I mean, in contrast, for example, as we all know, we're very excited with the long-acting cabotegravir from the Men Who Have Sex with Men study, and there you could really see how many infections were occurring, because you knew that people were taking that injection, so you could really monitor that much more closely. So it is difficult. So I'm rambling, but what I'm wanting to say is we will look at all the evidence. So we will include both the studies, the open label. We will also look, and there was some analysis from the original 2 studies which looked at women who did and didn't use at all, which again, in the women who did use compared with the women who didn't use at all, there was greater efficacy. So all of these will be taken into consideration. But I just wanted to go back to the previous question, and I think on why haven't we done better at scaling up oral PrEP? Well, we haven't done as well as we should. We still have really made some inroads, and there are some particularly countries like Kenya and Lesotho which have really started to roll out oral PrEP for women. And I think there are problems with continuation, but we shouldn't be despondent about that at the beginning. And I think it's really important. This is why it's so important for the community and for advocates to know all about oral PrEP and other choices, to offer women choices, and also support them through. They may want to start today, they may want to stop, they may want to come back on. And all of these should be really supported. Thank you.
Thanks for that, Rachel. A couple of questions. Mudilan, sorry if I'm saying your name wrong, asks about trans men and trans masculine folks and others with front holes or otherwise. Can we hear about efforts underway to keep this energy and considering rings and other biomedical prevention for trans masculine folk? And another question I'm going to ask, because I'm sending both of these to you, Zita, is these are questions that came when people were registering, was about this need to collect additional efficacy data. And you mentioned it in your slides, but please can you tell us more about your plans for that study and this additional efficacy data to be collected? So let me send both of those to you, Zita.
Sure. Thank you. I think the question about trans men is a really important question. And it's something that we really haven't looked at yet. And I would hope that our colleagues in the research community would have that on their agenda. And we certainly can work together with them, with the ring. And hopefully they're looking at other HIV prevention methods as well. So I think it's a very important question. And I've already blanked on the second one. I'm sorry. Oh, no, I blanked on it.
Additional efficacy data needed and the plans?
Yes. The EMA often requires what they call post-authorization efficacy studies and other requirements. And it is something that they would like because of the lower efficacy seen in the studies. In the ring study, it was not statistically significantly different than in older women, but clearly younger women, 18 to 21, had lower efficacy and also lower adherence as measured by how much drug was left in the rings. And so they would very much like additional data on this. And it's, you know, as everyone knows, at this point in time in the HIV prevention field, we happily have multiple options. So it will be very, very difficult to try to compare the efficacy of the ring to oral PrEP because we won't know clearly adherence in either one very well. So we are proposing an additional open label study where all women will get access to the ring, and we will be able to estimate, hopefully, incidence in the absence of the ring through data from ongoing and recently completed studies in similar populations. But their question really was around you know, the relatively lower efficacy in younger women. There were no concerns reported or at least mentioned around safety. And there were also, they would clearly like to see additional data on potential for resistance that was not seen in the trials. And of course, the trials are designed to minimize any potential for resistance. And so that's additional data that they would like to see, but not, it does not condition at all the positive opinion.
Thanks very much for that, Zita. And with that, I first want to tell everyone who sent in tons of questions. I want to apologize for the many questions we didn't get to, but I hope that we were able to get answers to some of them. For many of the questions that have come in, we're going to work with our colleagues in IPN and MTN and WHO to see if answers to these are in their FAQs or other places. And those that do not have answers, we will try and get those answers and integrate them into some of our materials. We will also send out a recording of this call to everyone, and I'm sure there will be more information and more opportunities to discuss this. I really want to thank all the 4 presenters and especially for coming, and Zita and Rachel for taking on so many questions. I hope you all heard how excited everyone is and that everyone is looking forward to the hard work it will take to go forward. And I also hope you heard, especially Rachel and Zita, how anxious and excited advocates are to be part of the process and the decision making. So we really look forward to that as well. And so with that, I'm going to hand back over to Mitchell, but really just thanking everyone for being with us today. And back to you, Mitchell.
Great. Manju, Ruth, Cleo, Rachel, Zita, thank you all so very much. This was remarkable. As Manju said, lots of great questions, both about what we do next with this particular Dapivirine vaginal ring, but also some really great questions about the additional research areas within this product, as well as the larger prevention research landscape. So lots and lots to talk about. I do want to just quickly say 2 quick things. And I think, Levi, if you go to the next slide, I mentioned at the beginning, and I'm just so happy that Zina is on. And I want to flag people's attention to the very last piece. This is an abstract from her paper in 1990. Cleo, you weren't even alive then, I think. And some of us already had gray hairs then. But 30 years ago, Zina published this article. And it is remarkable how prescient she was. And you'll notice at the very end, she talks about a topical viricide, renamed a couple of years later as microbicide. But I just really want to acknowledge that this has been a long, arduous journey. And Zina, I'd love to hear your voice if you have any thoughts to share really quickly before we close.
I want to say something. I just want to know if you want to say something, Mom.
Thank you very much.
It's a long time since you and I met and started working together. This is a wonderful point. By the way, I'm 98 and it's my birthday, so you couldn't get a better present.
Zina, it is so great to hear your voice and remarkable to celebrate your birthday and that you are 98. You have inspired generations of us who've worked on women's health, HIV prevention, sexual reproductive health, and I am so glad you are here. I also just want to say to everybody else, if you do the math, Zina pioneered this field when she was 68 in 1990. So we all have a lot to do before our 98th birthdays with the Dapivirine vaginal ring, with everything else that we need to do. So it's never too, you're never too old to start this journey, and to think that in 30 years, Zina, what the collective community have done to realize a vision that you established. So I think on behalf of all of us who've been your students and mentees, thank you.
Happy birthday.
And for those who don't know, Zina has been at Columbia University for many years, but she and her husband, Mervyn Susser, were pioneers of primary healthcare in South Africa decades ago. And so we all stand on their shoulders for more than really 60 years of their careers. And maybe that's a nice segue also to now the very last slide. One of the things we've learned all along is that these regulatory processes are not, and Zita now knows this all too well, they're not the beginning of the end. They're the end of the beginning of product development. Now the hard work begins. How do we make it real? And just a quick shameless plug for another webinar tomorrow at 9 a.m. Eastern time, along with FP 2020, and actually Rachel Bagley will be there as well, and other advocates joining to talk about how we, a year after the ECHO trial that Yvette mentioned, how do we look at integrating sexual and reproductive health and rights and HIV? Again, something that we shouldn't have had to be doing 30 years later. We've said it for decades. We need to do it. And so I really want to invite all of you to join that call. And I think it relates to the Dapivirine vaginal ring. It relates to Eric's question about the ring and PrEP. And it relates to a number of great comments about rings and both for contraception and for HIV prevention. What we heard so loudly and clearly in the ECHO results a year ago is that women want to go to one place at one time to one provider, and eventually, hopefully soon, with one product to meet their sexual and reproductive health needs. That is a vision that grows on Zina's 30-year-old vision, and that IPM and MTN have at least provided a foundation for with the Dapivirine vaginal ring. So a moment of great celebration of people's lives well lived and celebrated here. And just want to thank everybody for getting us to this point, and more importantly, really everything that we've all done for the last 30 years was easy. The hard work begins, and I look forward to working with everybody. Thank you, Manju, Ruth, Cleo, Rachel, and Zita, and Zina, and everyone else, and let's get back to work. So thank you all.